skeletal muscles, like muscles automatically used, like muscles of eye movements, eyelids, bulbar muscles, and other skeletal muscles. What is neuromuscular junction? Basically, it is formed by between a motor neuron, axon, and muscle fiber that it innervates. Here you can see formation of neuromuscular junction, and microscopically you can see the motor neuron axon with synaptic vesicles, and this is postsynaptic membrane, which is muscle membrane. This is called a neuromuscular junction. What is neuromuscular transmission? Acetylcholine is basically a neurotransmitter that is used at nerve and muscle junctions. It is released from nerve terminals and it binds to receptors on postsynaptic muscle membranes. That leads to increased conductance of sodium and potassium, leading to transient depolarization called end-plate potential, which allows for generation and propagation of action potentials in muscles. Acetylcholinesterase is basically an enzyme that is present in synaptic vesicles, synaptic cleft, and it degrades excess acetylcholine, so prevents untoward muscle action potential. This is how the neuromuscular junction and its transmission of current occurs, starting with depolarization of nerve terminals. This is depolarization of nerve terminals by current flowing through the axon of motor neuron. It leads to opening of calcium channels. Opening of calcium channels at the axon terminal, and that ultimately causes what? It mobilizes membrane-bound vesicles containing neurotransmitters, and they fuse with the membrane, leading to release of acetylcholine in the synaptic cleft, which binds to postsynaptic muscle membrane. These are same steps that we discuss. And acetylcholinesterase basically causes what? Degradation of the excess acetylcholine present in synaptic cleft, so that an untoward and action potential may not propagate in muscles. This is a very important and conceptual list of neuromuscular junctional disorders. It is not only Myaesthenia gravis. Myaesthenia gravis is a post-synaptic neuromuscular junctional disorder. Like snake poison, majority or many of the snake poison also causes post-synaptic neuromuscular junctional disorder with weakness of muscles. But there are also presynaptic and synaptic neuromuscular junctional disorders. What are the important presynaptic? Botulism, Lambert-Eaton myasthenic syndrome. Synaptic neuromuscular junctional disorders are in fact more common than these postsynaptic. You must have seen cases in Department of Poisoning Center in JPMC in Ward 5 medicine ward, where the patients with these synaptic neuromuscular junctional disorders after accidental or intentional insecticide poisonings are present. And this is how the different disorders cause the neuromuscular junctional problem. For example, Lambert-Eaton myasthenic syndrome with aminoglycoside antibiotics, these calcium channels over here, entry of calcium channels is blockade. So it also causes weakness of muscles. Botulism, it causes what? Or it inhibits the release of acetylcholine in the synaptic cleft. Myasthenia gravis that we will discuss, it is because of this antibodies that damage these postsynaptic receptors on the postsynaptic muscle membrane. So myasthenia gravis is basically an autoimmune disorder which is caused by acetylcholine receptor antibodies, which causes destruction of postsynaptic muscle membrane by binding to acetylcholine receptors. And it leads to, or it prevents binding of acetylcholine to postsynaptic membrane. It is an example of blocking autoantibodies. Here you can see normal postsynaptic muscle receptors for acetylcholine, and with these acetylcholine neurotransmitter, when they bind, they cause muscle activation. While here, these blocking antibodies, they block the binding of binding of acetylcholine at postsynaptic membrane, leading to muscle activation, which is inhibited. So there are three types of acetylcholine receptor antibodies. They may be binding, they may be blocking, and they may be modulating. But all of these lead to receptor loss on postsynaptic membrane and decrease postsynaptic membrane potential. So antibodies, there are also antibodies other than this, but the most important is this acetylcholine receptor antibody. Which are other antibodies? For example, antibodies to other protein on postsynaptic membrane, which is called muscle specific kinase. So anti-MuSK antibodies, they are present in 40% of patients who are negative with this antibody, acetylcholine receptor antibody. There are also antibodies to striated muscle proteins such as titin and vinodine, especially in patients with thymoma. What is clinical presentation? How patient presents? It is characterized by fluctuating fatigable weakness of commonly used muscles, as we discussed. And the hallmark features of Myasthenia gravis include ptosis, diplopia, dysarthria, dysphagia due to the weakness of bulbar muscles, and respiratory and limb weakness. 50% of patients may present only with ocular symptoms like with ptosis or sometimes with ophthalmoplegia, and it remains localized to it in 10% of Myasthenia gravis patients. Means in 10% of patients, Myasthenia gravis may be localized to only muscles of eye. 30% patients present with limb weakness. So majority of patients present with eye symptoms, eyelid ptosis, for example, ophthalmoplegia, and 30% present with limb weakness or proximal muscle weakness. In 1/3 of Myasthenia gravis patients during pregnancy and postpartum period, symptoms may be exaggerated. During pregnancy, especially in second and third trimester, in first trimester, and during postpartum period, symptoms may be more pronounced in Myasthenia gravis patients. On examination, what will you see? Important signs, ocular signs that you must see in any patient that you are suspecting Myasthenia gravis. You have to see for ptosis, you have to see for diplopia with eye movements, and you have to see if there is any obvious ophthalmoplegia or restriction of eye movements in any gaze, for example, lateral gaze, medial gaze, downward or upward gaze. This is very important in clinical examination. You will see that sustained upgaze for 30 or more seconds will induce or exaggerate ptosis. If you are suspecting ptosis, but it's not so obvious, so you have to ask patient to look upward sustainedly for more than 30 seconds, and if there is myasthenic weakness, it will exaggerate. Unilateral pallidus ptosis without ophthalmoplegia or pupillary abnormality most often prove Myasthenia gravis. Bright light, for example, sunlight, it aggravates, while cold improves ocular signs. This is also sign of or symptom of myasthenic weakness. Muscles of facial expression, swallowing, speech, and mastication, because they are very commonly used muscles, skeletal muscles, though are commonly affected. In limb muscles, generally proximal muscles are more affected than distal muscles. For example, shoulder and hip muscles are more affected than distal muscles of limb. While on examination you see that tone will be normal, reflexes will be normal, and sensory examination should ideally be normal in all patients with Myasthenia gravis. This is a picture showing you bilateral ptosis in a child. Here you can see ptosis on bilateral side. What is myasthenic crisis? It is also an emergency presentation of myasthenia. Sometimes patient may present with even directly first time with myasthenic crisis, but majority of cases with myasthenic crisis are those who have underlying Myasthenia gravis. So when myasthenic patients present with bulbar, for example, dysphagia, dysarthria, and hoarseness, and respiratory symptoms, for example, weakness of diaphragm and intercostal muscles. This is called myasthenic crisis, and it complicates around 15 to 20% of patients with myasthenia gravis. It may be triggered by infections or aspirations or other problems leading to acute crisis with myasthenic weakness. Prevalence of myasthenia gravis is around one patient is maybe present with myasthenia gravis in a population of 10,000 to 20,000. And usually women are more affected in second and third decades in younger age, while the men are more affected in older and middle age group like in fifth and sixth decades. Autoimmune diseases are present in approximately 5% of patients, and comorbid thyroid disease may occur in more than 10% of patients with myasthenia gravis. These are very important tests to remember, and it may be an important question in your exams for investigation of myasthenia gravis, starting with Tensilon, edrophonium test, or laboratory test, electrodiagnostic studies, imaging and other studies that we will discuss briefly. What is Tensilon edrophonium test? It evaluates the response of a short-acting cholinesterase inhibitor called edrophonium. So it increases acetylcholine levels in synaptic cleft because of its inhibiting effects on acetylcholine, and it will result in increased postsynaptic transmission and will improve muscle power because of more acetylcholine present in synaptic cleft. It is a very sensitive test, but it is not so much specific. It may be present in other muscle weaknesses like in motor neuron disease and other myopathies. While to reverse its side effects, atropine should be available because it can cause very serious side effects, muscarinic side effects, for example, bronchial secretions in bradycardia. This is a simple bedside clinical test called IVIG test, which was routinely used before, but now it is not so commonly used, and it is a bedside test and very quick test for diagnosing myasthenia gravis, in which you apply the ice cubes. Patients with ptosis, a small cube of ice is placed over the eyelid for about 2 minutes. There should be improvement of the ptosis after this procedure that suggests a disorder of neuromuscular transmission. While ptosis due to other conditions, for example, in patients with third nerve palsy or other problems, that will not improve with application of ice packs. Usually, local cooling improves safety factor of neuromuscular junctional disorders, possibly by what? By slowing the kinetics of acetylcholinesterase. This is the result of ice pack test in a patient. You can see here ptosis. After application of ice pack, you see there is a visible improvement of ptosis in the second figure. What are other laboratory tests? Very important is acetylcholine receptor antibody test, which is present in more than 90% of patients with generalized myasthenia, while 50% of patients, if it is only or pure ocular myasthenia. In patients who have negative acetylcholine receptor antibodies, you can also order this antibody test called anti-MuSK antibody test, which can be present in up to 40% of patients with negative acetylcholine receptor antibody test. While you must order for autoimmune tests like ANA, RA factor, and thyroid stimulating hormone test also, because they may be comorbid associated conditions with myasthenia gravis. Very important tests, electrodiagnostic studies. What are the electrodiagnostic studies? In which we see nerve conduction study, we check for electromyography, but the routine studies like nerve conduction study and the electromyography are unremarkable in patients with myasthenia gravis. You have to apply specific and other protocols of nerve conduction study and EMGs called repetitive nerve stimulation and single fiber EMG. Repetitive nerve stimulation is basically what? It is most commonly used test to evaluate for myasthenia gravis and very sensitive test. In more than 80% of cases, you can find test positive result, especially with generalized myasthenia. What happens in repetitive nerve stimulation? You apply repetitive stimulation of nerve, and you see for the action potential or response of the muscle that it innervates. If there is decrement of more than 10% in the muscle, it is suggestive of decremental repetitive nerve stimulation response, and it points to neuromuscular junctional disorder, especially myasthenia gravis. While this very advanced test now routinely applied single fiber EMG, which measures basically what variability in synaptic transmission time, which is called jitter, between two muscle fibers which are innervated by same axon. And this variability basically is increased in myasthenia gravis, while normally this variability is not increased. This is the action potential that you can see here with normal response in patients with decremental response in myasthenia gravis. Here you see the repetitive nerve stimulation causes same amplitude of action potential in normal muscles. While in patients with myasthenic weakness, you can see there is decremental response of action potential. Here you can see the potential highest first, then it decreases respectively in subsequent nerve stimulations. So it is more than 10%. If you can see here and here, the action potential is decreased more than 10%, and it is suggestive of myasthenic gravis weakness. Imaging, especially CT or MRI chest, is very important and should routinely be done in all patients with myasthenia gravis because of the association of the myasthenia gravis with thymoma and thymic hyperplasia. Here you can see thymoma present in patient with myasthenic weakness. In majority of patients, it is thymic hyperplasia, which is benign condition, while thymoma may be associated in 10% of myasthenia gravis patients. What are the important differential diagnoses in patients with myasthenia gravis? If it is generalized myasthenia gravis, then you must, which is more common, then you must suspect these presynaptic disorder like Lambert-Eaton myasthenic syndrome, botulism, myopathy, ocular myasthenia. Sometimes it is the only long-term presentation in myasthenia in 5%, 5 to 10% of patients. Then the differential diagnosis with ocular myasthenia with only eye movements problems is progressive external ophthalmoplegia, which is type of mitochondrial myopathy, thyroid disease, hyperthyroidism, oculopharyngeal muscular dystrophy, which is basically a muscular dystrophy like Becker's and Duchenne muscular dystrophy. This muscular dystrophy is limited to eye muscles. Bulbar myasthenia, sometimes myasthenia can be limited to bulbar muscles. And what are the treatment options in myasthenia gravis? Initially, you have to start with symptomatic treatment with long-acting acetylcholinesterases like pyridostigmine, neostigmine. Majority of patients ultimately have to be started on immunosuppressive therapies because it's an immune modulating disease, immune mediated disease, autoimmune disease. So immunosuppressive therapies have definite role. These all therapies are basically immunosuppressive therapies or immunomodulating therapies. So systemic steroids, azathioprine, cyclosporine, methotrexate, cyclophosphamide, surgical thymectomy also causes immunosuppression and remission of the myasthenia gravis. Plasmapheresis and IV immunoglobulin, especially they are used in acute or in flare-ups of myasthenic weakness. To start with symptomatic treatment, which is a mainstay of treatment, and the cholinesterase inhibitors are basically used, which increase concentration of acetylcholine receptors. What are these cholinesterase inhibitors? Pyridostigmine, neostigmine, and edrophonium. And they are very effective early in the disease. Sometimes in mild disease, they are the only drugs that are used. Side effects due to excess acetylcholine at nicotinic and muscarinic receptors can be very untoward, like diarrhea, cramping, excess secretions, which are muscarinic side effects, while muscle fasciculations, increased muscle blockade, increased blockade of neuromuscular transmission, which are nicotinic side effects. They can lead to cholinergic crisis. So neostigmine, pyridostigmine, and ambinonium, edrophonium, these are different type of. Pyridostigmine is the only one that is available in our country, and we commonly use it. here in our neurology setup. It is available by the name of Mestinon and Amigra. Immunosupressive therapy, again, they are systemic corticosteroids and immunocorticosteroid sparing agents like isotretinoin, mycophenolate, cyclosporin, cyclophosphamide. Corticosteroids are basically the first line of immunosuppressive therapy, and they induce remission in majority of patients. But you must monitor and see for the complications associated with long-term usage of these corticosteroids like hyperglycemia, hypertension, cataract formation, osteoporosis, avascular necrosis of hip bone, psychosis. While these non-steroidal immunosuppressive agents are used for long-term management, because you cannot continue with corticosteroids for long-term basis due to their very serious side effects if you use chronically. So they are used as either as adjunctive or steroid sparing agents for long-term immunosuppression. Their side effects include bone marrow and hepatic toxicity, hypertension, renal toxicity, GI symptoms, and long-term risk of malignancy. So you have to periodically monitor blood counts, liver function tests. IV immunoglobulins in plasmapheresis is what? Basically, it is a short-term treatment for acute flare-ups of disease, and is also used as a short-term treatment in patients with myasthenic crisis. They both are highly effective, and they induce rapid clinical improvement in patients with myasthenic weakness. And they are used in special situations, which are myasthenic crisis, acute exacerbations. Myasthenic crisis and acute exacerbations difference is what? Myasthenic crisis you will label when there is either bulbar weakness or respiratory weakness, while limb weakness and more serious ophthalmoparesis, ptosis, this is called acute exacerbation. Prior to thymectomy, sometimes you go for either plasmapheresis or IV immunoglobulin to stabilize the patient. Even before starting steroid therapy, sometimes to stabilize the patient, you have to give IV immunoglobulin and plasmapheresis. Thymectomy also causes what? Basically, it is also an immunosuppressive surgical procedure in patients with myasthenia gravis. Because in 10% in which there is thymoma, its removal is must. While in patients, others with thymoma or thymic hyperplasia, it increases what? It increases the long-term remission and induces remission. And it should be considered for patients of any age unless there is some clear contraindication to surgical procedure. While it is more effective when you perform during first 2 years of life when you have myasthenic weakness in any patient. There are many drugs that can precipitate myasthenia and cause myasthenic weakness, especially anti-infective drugs acting at postsynaptic membranes, or in neuromuscular transmission. They have side effects, cardiovascular agents and other agents, especially aminoglycosides, as I showed in a picture. They may block the calcium entry in presynaptic membrane. Ampicillin, ciprofloxacin, erythromycin, imipenem, kanamycin. These cardiovascular agents are also very important to remember, and they are contraindicated in patients with myasthenic weakness with propanol, verapamil, quinidine, procainamide, and other beta blockers. Beta blockers and calcium channel blockers. These are usually the drugs which are avoided in patients with myasthenia gravis. Other agents like chloroquine, corticosteroids initially sometimes make worsen myasthenic weakness, D-penicillamine, phenytoin, and midodrix. What is the prognosis of patients with myasthenia gravis? 80% of patients with focal onset, they may ultimately progress to generalized myasthenia gravis. And progression to maximum severity typically occurs within the first 2 years. In the first 2 years, you have to see what is the progression to maximum severity. Spontaneous long-lasting remission may occur in 10 to 20% of patients, and most patients enjoy a normal and productive life when they are adequately treated. While patients with underlying thymoma, they have more aggressive course, so surgical thymectomy is necessary in all these patients. Thank you very much. I hope I have discussed the more and core features of myasthenia gravis. and you can post me your queries if you have. Thank you very much.